Welcome everyone. I could say good morning, good evening, good afternoon, depending on where you are watching around the world. It's an honor to have you all participating, and especially also, of course, to our panelists today. So I'm Colin Christie. I'm the Executive Director of Global Chamber here in Metro Manila, Philippines. And very excited to have this first of our Asia virtual events dealing on the topic of healthcare innovation. So one of the missions of Global Chamber, of course, is to build trusted connections and contacts and networks around the world to encourage and stimulate sharing of ideas, of innovations, of best practices and case studies. So that was really the motivation today, to bring together experts in the area of healthcare, especially from a broad array of emerging countries, where the challenges are often steep in bringing, high quality medicine and coverage and access to the broader populations. So with that, I'll just give a brief introduction to the panelists, and then I'll allow them to introduce themselves further. So joining us today from Pakistan is Haris Adnan, who's the supply chain manager of Shifa International Hospitals. So Haris, good to see you. Thanks for being here today. We also will have joining us in a moment Will Greene, who's the founder of Tigermine Research based in Vietnam, but Will is actually well known for his business and technology writings on the subject of healthcare, published in publications including Forbes and others. And then also we have Carl Eng, who's the Chief Revenue Officer of LifeTrack Medical Systems based here in the Philippines, and a provider of some really innovative distributed radiology solutions. And then as well as Sumana Shrestha, who's the founder of Medication for Nepal. It's great to have you here, Sumana. And then finally, Reggie Valente, who I think also will be joining us momentarily, who is the CEO of Novastorm Technologies here in the Philippines, with some really interesting analytics and data solutions for real-time monitoring of patient flow in hospitals and in clinics in order to bring more timely treatment of patients. So just a really great diverse panel. So thank you to all of you for being here. So I think with that, what I'd like to do is then just have you introduce yourselves a little bit further and talk a little bit about your organization and the focus of what you're doing. And Haris, if it's okay, I'll ask you to lead off with that.
Yes, thank you very much, Colin, for giving this opportunity. It's a great opportunity to present Shifa International Hospital before you and before all. I'm serving Shifa International Hospital as a supply chain manager. Shifa is a great institute here, which has evolved during the last 27, 28 years. Let me take you through quickly through the history with which Shifa has evolved as a great institute here in Pakistan, serving with great compassion for the patients here in the state. So this is Shifa International Hospital, located in the shadow of Margala Hills, in the beautiful city of capital of Pakistan, that is Islamabad. Let me take you through the journey where Shifa has been through. Shifa basically works with a vision of compassion, healthcare with compassion for all. Shifa started its journey in 1993, took its first patient, and then the journey went through. When we started with one clinic with around team of 20 people. And now in 2017, we have, a huge facility here. We have around 4,000 plus employees working here, serving the patients. We have critical care facilities. We have 100 plus bed critical care units here, surgical ICU, medical ICU, and all that. And we do have 500 plus beds here to accommodate patients from throughout the country and international patients as well. Through the journey, Shifa evolved as the building you are seeing on the screen. It started from one block and then evolved as a big institute. We have state-of-the-art equipment here. We have state-of-the-art 18 OTs here, which are modular as well, equipped with the latest equipment. From day one, the group of doctors who started the hospital, especially the founder, Dr. Zahir, who came from all the way from America with a vision, with a mission to start the same level of facility here in Pakistan that he has been working in USA. That was the vision. With that vision from day one, Shifa basically strive each day to remain leader in innovations. Shifa had this vision that we have to lead all the innovations, the technology in the country, so that we give at better cost, good quality care to our patients here in Pakistan. We, through that journey, we haven't just acquired technology, which is of course a challenge that we will discuss when we further go into discussions. We also with great focus worked on information systems. For example, we have filmless X-ray reporting throughout the hospital. We have PACS being implemented here, very good technology that enables the consultants, the technicians throughout the hospital. They can see the X-ray reporting online. That is very helpful. Likewise, we have laboratory online here throughout the hospital. So the diagnoses are there in the information system for all the consultants all the time here throughout the hospital. That being integrated with another information system, which is medication ordering and administration record system. We call it MOAR. MOAR basically gives facility to the consultant that right at the time of prescription, it gives certain checks as well, validations as well, and it helps a consultant in prescribing the right medicine with minimum errors. And that being integrated with through the process up to the nurse actually dispensing medicine to the patients. So all the way the information systems are integrated. Pharmacy, when the request goes to the pharmacy, pharmacy can validate, verify the drug prescribed with the help of lab diagnostics available, radiology diagnostics available with the pharmacy team. So everything here is with the vision that things should be online, things should be automated, things should be with minimum human intervention to avoid prescription errors, to avoid diagnostic errors, for providing better quality care to the patients. With this vision, we have been working in Shifa International Hospitals, and the pride that the hospital has throughout the country, throughout the region, is that Shifa is the only institute that is doing 4 organ transplants under one roof. And the biggest pride is that Shifa is doing liver transplant very successfully here. We have done around 350 plus successful liver transplants here in Islamabad. So that's a great pride for Shifa, being ahead in the region in the organ transplants. The other transplants that we do are kidney transplant, we do bone marrow transplant here, and we do cornea transplant here. Then Shifa has recently been accredited with JCI, Joint Commission International Accreditation. That was a great journey for Shifa. For achieving that credit, Shifa has transformed all the processes revolved around patient safety, because JCI is all about patient and your staff safety. So now Shifa has that pride, carries that pride that the Shifa team is JCI accredited as well. That becomes complicated. Another pride is that becomes complicated when you're doing transplants as well in the hospital, and especially liver transplant, because the documentations, the information systems, the patient safety, the patient criticality, your requirements in the critical areas, your requirements in the operation theaters, your requirement of the facility, that gets really complicated when you're doing transplants as well. So it's a great pride for Shifa that we worked really hard here as a team, and we helped our institute transforming into a patient safe, a safe place for patients where they come and do and they are very less prone to hospital acquired infections. So that's the journey that Shifa has been through. As the subject today is that how we have been contributing into bringing innovations in healthcare in the region. We have, as I said, we started from a very small unit, and since then, with the vision that we need to bring innovations in the region, we have been striving. Shifa also has a Shifa Foundation that helps improving affordability of patients, because when you invest in expensive technologies, you have, as you all know, that we have thin profit margins in healthcare. So capitalizing a huge amount and getting very less return, that is a difficult situation for the hospital as well as for the patients. So Shifa has sister organizations as well that help the patients who cannot afford such level of quality care. That is the helping hand which improves affordability. Then the last but not least is that Shifa has contributed innovatively into the education and training side in healthcare as well. We have a Shifa Tamil Millet University here, which has School of Medicine, School of Nursing, School of Technical Education, and numerous other schools through which Shifa is producing skilled people here for the region, not only for the Shifa. They get trained here in a big institute, and then region acquires the hospitals, other hospitals in the region acquire those skills, and we never mind that. We do that with the vision that we are not doing it just for Shifa, we are doing it for healthcare improvement in the region. Thank you very much. That's it from my side.
Excellent, Harith. Well, first of all, congratulations. You've obviously been through a journey of many learnings, I'm sure, and we look forward in the panel section, for you to maybe share some of the challenges that you had along the way, and then how some of the innovative approaches, resolved those. So with that, then I think our next introduction will be Will Greene, who's the founder of Tigermine Research, based in Vietnam, and who's covered health tech broadly in Asia, and covered innovations with Asia. So Will, I'll allow you to just maybe introduce yourself a little bit further with background and talk a little bit about some of the experiences that you've had in the region here.
Sure, happy to. So hi everyone, and nice to be here. It's an interesting group of people, nobody who I've met before, so happy to be connected with all of you. In short, I run a company called Tigermine Research. This is an advisory firm, largely for science and technology organizations in the region. Beyond that, I am probably better known for my journalism work because I've been writing about healthcare and technology in Asia for about 4 years now. And I've written for a lot of different international media publications. This is how I met Colin, because about 3 years ago, I did a piece on LifeTrack, which I thought was a very interesting company. And so I guess, in terms of background, I've been in the region for 6 years. I quite like Asia. I find this is a very fast developing part of the world. I think that it's an area where there's a lot of interesting healthcare problems to be solved, and a lot of interesting ways that people are either bringing in technology from the developed world or developing their own homegrown technologies here to deal with the region's unique challenges. So I've been writing about different organizations, companies, individuals who have been doing that in various ways for a few years. But journalism doesn't really make you very much money, unfortunately. So I spend only about 20% of my time on the journalism and 80% of my time on my consulting business. And I work with companies like the ones you're representing. I largely do investigative research. I do marketing, and I do strategic advisory and operational support. So case in point, one of my biggest clients for the last couple of years is a company called Int'l. This is a company that started in the Philippines. The founder of that company is an advisor to LifeTrack, I believe, a guy named Farouk, who you guys may have met. And I took this company and I helped them enter the Vietnam market, helped them go to Indonesia, and helped them launch some programs in Thailand. So that's me in a nutshell. And I'm happy to hear from the rest of you today. So, and looking forward to the Q&A session. One thing though, since I've been brief in my background, it might have been that I came in a few minutes late due to some technical difficulties, but Colin, did you give an overview of what Global Chamber is that I missed or something? Because I have no idea what this even is.
Sure, yeah, and I'll come back to that towards the end. I did give a brief introduction, so I'll tell you what, at the end when we wrap up, I'll cover that again. So yeah, sorry, I know we had a little bit of technical difficulty with the video, but all good now, looking good. And Will, it's great to have you. Both hats that you wear, so to speak, both on the journalism side and on the advisory side, is tremendous and actually very in line with what we're trying to do with Global Chamber, which is the idea of the concept of taking really great innovative ideas and spreading the word, so that they can be more broadly applied, that people become aware of innovations in one area that have great application in other areas, right? And so oftentimes things are a bit too siloed and people are not aware of how to make the trusted connections, and that's what we're trying to do, both generally and also with this event. So looking forward to exploring that further in the panel, in the discussion section.
Yeah, well, last word then, which is that I'm still amazed that there's nobody else who's doing this, who's doing what I'm doing, which is telling the world the story about the opportunity for healthcare in Asia. I mean, this is an incredible story. There's incredible transformations happening. And even more importantly, there's incredible opportunity for transformation. And so, I invite you to help me help you, tell your stories. So I look forward to hearing all of your stories today.
That's fantastic. All right, great. Thanks very much, Willa. So then I'd like to also introduce Rubaiyat Khan, who's the founder of, I'm not sure if I'm pronouncing it correctly, is it Gion, or how do you pronounce the organization? Go ahead, in Bangladesh.
Thank you, Colin. And I'm also extremely honored to be part of this amazing panel. Great to hear from you, Haris and Will. So my name is Rubaiyat. I am based in Dhaka, Bangladesh. As you know, it's the 6th or 7th most populous country in the world. and the densest country in the world. So it's a great place for healthcare innovations, to be honest, because there's just a lot of problems to be solved. So my personal background was in technology and in social sciences, and Geon is basically a 2-year-old company. It's a startup still, and we're trying to address the rural healthcare challenges in Bangladesh, specifically in terms of curative care. Because as you know, emergencies and preventive care, these are usually the domains of governments in most rural areas. But there's a huge gap in the curative space because, and also in chronic care, because doctors are in really short supply in countries like Bangladesh. And unlike in urban areas, actually there is a huge discrepancy in doctor density between urban and rural areas in places like Bangladesh. So just to give you an example, in rural areas of Bangladesh, we have only 1 doctor for 10,000 people, whereas there's about 20 doctors for 10,000 people in urban areas, which is still small, but in the rural areas it's just terrible. And in the absence of doctors, what often happens is people end up traveling to going to their neighborhood pharmacy or the quack doctor or even a homeopath or other traditional healer for any kind of curative problems. And what that ends up resulting in is a lot of, first of all, they delay care seeking. They don't seek care until it's too late. It leads to more emergencies and health shocks. There is a lot of obvious malpractice and exploitation in that market because it's not heavily regulated. And because pharmaceuticals are really widely available in Bangladesh, it's also leading to a lot of long-term problems like antibiotic resistance, because a lot of these pharmacies are actually dispensing high-grade antibiotics and steroids to people quite freely without prescriptions. So the way we are trying to address this problem is by working with these informal providers rather than trying to subvert them, as the government has traditionally tried to do. So instead of saying, let's go build a clinic or a facility in these rural areas, we're trying to leverage the existing trust networks that these informal providers have and trying to upgrade that infrastructure into better providers of primary healthcare. So essentially how that works is we select pharmacists in village areas, in rural markets, and we train them and equip them with technology, including a tablet, including some basic vitals machines, including ECGs and other small rapid diagnostics. And we have built our own electronic medical record system where they can capture all of this information in a very simple format and then send it off to the doctors via the internet. And once they send it off, doctors in Dhaka, in the capital city, can actually look at that information, have a voice or video call with the patient, and then submit a prescription that gets instantly printed on the other end. So essentially, any rural person who's coming to a pharmacy for buying off-the-shelf medicines, instead of just buying the medicines, they can also get a consult from a qualified doctor in the country. And we've seen about, we'll be soon seeing about our 10,000th patient. So it's been a pretty steep learning curve for us in the last 2 years. And we're constantly figuring things out. And there's, of course, a lot of things breaking, as you can imagine. But we're learning from every bit of them. And we're hoping to scale across Bangladesh in the next few years. So that's, I'll stop there. And then maybe in the question answer round, I can elaborate further.
That's great. Yeah, that's a great example of being able to take leverage technology to broaden out the population served, especially I think a very common problem through the region of the number of patients needing care versus the number of trained physicians, right? So that's something we really want to explore further with you. I know that's of great interest here in the Philippines as well. So speaking of the Philippines, I'll introduce Carl Eng, who's the Chief Revenue Officer of LifeTrack Medical Systems, addressing the diagnostic side of the challenge. And Carl, I'll allow you to just further introduce yourself and talk about the problem that LifeTrack is addressing. You're muted, by the way.
I thought you were the one who muted me. Hi, everyone. Thanks for the invitation to join, Colin. It's great to be on the panel with everyone. And everyone seems really passionate about improving healthcare in their own way. Similar to what kind of Rubaiyat just said, LifeTrack is also trying to enhance access to medicine and in particular diagnostic imaging. And the big problem we're trying to solve is if you look at radiologists in emerging markets like the Philippines or Indonesia, and I'm sure Bangladesh and India as well. In the US, there are 90 radiologists per million people. And in a country like the Philippines, which has 100 million people, or Indonesia, which has 230 million people, there's only 10 radiologists per million people. What that means is that people who need to be diagnosed for tuberculosis or need to have a CT scan done to detect if they have a stroke, these guys aren't getting the treatment they need because there aren't enough doctors around to read or to interpret the images. And similar, again, to what Rubaiyat said, it's also a doctor density problem where a lot of doctors are clustered in the big cities because that's where the big hospitals and the better hospitals are. They get paid more there. And so people on the periphery, people in rural areas where most of the population still resides, don't really get the chance to get access to diagnostic healthcare quickly or cheaply. So LifeTrack, we're a company built to solve that problem through technology. And in particular, the way we're trying to solve it is we have built our own radiology software, which is a platform that exists both in the clinic, but also on the cloud. And what we are trying to do is to create a model of distributed radiology. By putting the platform on the cloud, what we're doing with our customers now in the Philippines, but also outside of the Philippines, is we have diagnostic imaging chains that are building clinics in rural areas where there aren't any radiologists, and they're able to send their images, upload it to the cloud using consumer DSL or 4G even. And doctors that are based in the big cities like Manila are able to read those images for the patients and then get it back to them within 5 to 10 minutes. So the second thing we've done besides putting it on the cloud is because our technology was designed by a world-class radiologist, Dr. Eric Schultz, who was trained in Harvard Medical School and Massachusetts General Hospital. He really built the software with the radiologist in mind. He wanted to take out all the things that distracted the radiologist from diagnosing the patient and really make it as efficient and quick for the radiologist as possible. So we put in a lot of these productivity improvement tools for radiologists. And what we've seen is that we can make radiologists 5 times faster in diagnosing a patient, which means that even if the number of radiologists stays the same, you can at least increase the capacity of patients that they can see. And you can enhance the access to the doctors by allowing this technology and putting it on the cloud so that they can, even if they don't go to those remote areas, the images are sent to them and then they can send the diagnostics back. So LifeTrack's been around since 2012, but our commercial product was only launched last year in October. We've developed our own architecture from the ground up, which is why it can work in emerging market conditions using consumer DSL or 4G to send diagnostic images. We are not just in the Philippines, but we're also working with customers now in Indonesia, Vietnam, India, and we just got our US FDA approval in April, thanks to Colin. And we were able to now, we're starting to serve the US market as well, where even though they have more radiologists in emerging markets, there are particular areas of the US, like the Midwest, where there aren't that many radiologists as well. So I'm excited to hear about what everyone else is doing, and thanks for the opportunity to be here.
Excellent. And so I think, again, sort of a common theme of how to push out limited resources, to underserved populations and address those challenges in a resource efficient way. And so with that, I think, actually, I think I'll go first to you, Reggie. Reggie, you need to unmute.
Thanks a lot, Colin. Hi, everyone. Good morning, good afternoon, good evening, whichever part of the world you're in. My name is Reggie, and I'm from a company named Novastorm Technologies, and we're a technology transformation company. And I'm going to share with you the next 5-10 minutes what we do exactly. So I'm going to walk you through what pain point we're trying to solve, the solution which we've executed, and some of the outcomes that we've had so far. And heading straight to the problem, so this is very healthcare. And if you've been to a hospital, I'm pretty sure you've experienced, going in there and waiting to be attended, to be treated, to be admitted, and sometimes even if everything has been done on you at the hospital, when you're given a discharge order, it takes 2, 3, 4 hours before you're out. So it happens in a lot of hospitals, and patients get, they feel disengaged, disappointed, and a lot of times they complain, right? Now, on the side of the hospitals, it doesn't mean that they not do anything about it. They're actually trying hard. However, they just don't have the clinicians, they don't have the manpower around it, and it's tough for them to justify staffing. And they just don't have data because the systems are all over the place. It's disjointed, and they just don't have good solid means or basis for them to do improvement, right? So the one on their end, they really end up frustrated, tired, and appreciated despite all of their effort. However, so what happens with their IT? So hey, Reg, they have an IT, right? So, well, most of the systems focus too much on administrative, financial, billing data, and of course, a lot of focus as well on clinical data. It's their hospital. And a lot of this are out-of-the-box solutions, which are very expensive to customize. So what really happens is they end up sitting on top of a lot of data with doing nothing about it. Could be two things. One is they don't have the time and the manpower to do it, or two things, they just don't have the competency. They don't know what to do with data. And hence, there's a lot of opportunity being gone there from an overall improvement standpoint, but that's what it is. And imagine this is not just a problem of one hospital. This is a current scenario for our almost 2,000 hospitals in the Philippines and our almost 100 million population. I'm pretty sure wherever you're sitting, you may have seen this at one point or in one way or another in the hospital you've visited or you've been into. And hence, we wanted to make things better, and we wanted to do something about it. And this is how we're trying to solve it. So we have a patient flow management solution wherein we help them capture data for every patient care step using a data capture technology. And we convert that data into dashboard and analytics. So we basically convert data to useful information, and we help them with the improvement piece. Because sometimes, yeah, you give them the data, but they don't know what to do with it. So we go to the extent of helping them on improvement, and in our case, we use the proven methodology of Lean and Six Sigma. Okay, so how we capture data? Okay, so currently our primary mode of capture is to RFID. So it captures data in different types of RFID, obviously depending on how their process looks like, and it goes through the network. Okay, so our readers are strategically located, and data goes to the network, and it goes to a server. The business intelligence or business rules engine, which processes the logic of everything, and it will crunch these types of dashboard which you're seeing right now. So this pretty much shows the typical metrics which they have. They have their volume, they have the number of patients overstaying, they have the percentage of patients which they were able to serve within the turnaround time, and the length of stay. That's a metric which they have. It's a measure of how long a patient stays in a hospital. So that's nothing but the entry, the time the patient got in, and the time the patient went out. So this the average length of stay of our hospitals, and this in minutes. Typically with this, they have targets around it, with 3, 4 hours depending on the hospital. And what the dashboard also shows is the list of patients which are near approaching the target turnaround time, or patients who've gone beyond that. They've overstayed pretty much. So the dashboard that shows them that, and it triggers them to intervene. When they click on this, they'd be able to see which part of the process the patient was last seen, and hence allowing them to intervene immediately, right, without further delay, preventing further delay. Okay, so and then other than that, we also provide them with analytics. We crunch the data for them. We already have templates of reports. We could go from volume pattern, trend analysis, which gives them insight on how many staff they should have at a particular shift, which shifts they lack staff on and need to add, or which shift they have an excess on and need to move other staff to, even on their beds, like which parts of the day they need to add some overflow beds, where the delays are occurring, right, in the entire process, and even being able to dissect on which steps specifically needs to work on. And here what you'd see is a simple value stream map which highlights which particular steps they made significant improvements on, and in this case it's steps 3 and 6 and 7. So you'd see, say, from 14 minutes, it's now 10 minutes. From 137 minutes, it's now 118, and same goes with the other two. So it shows them that the solution shows them exactly where to work on, and once they're able to try something out, whether it worked or not. Because the thing is, it's a lot of experimentation as well. It doesn't mean that what you put in immediately will work, or it may not work immediately, so you have to try something else. So with this type of technology, it allows them to do a rapid experimentation of solutions that work, right? So we also give them guidance on, we do workshops with them in terms of process improvements, and that's how we capitalize on data. Okay, we use data and dissect the process further with them and see where the problems are, where the bottlenecks are, where they need to work on. And it's very collaborative, and a lot of the improvements, in fact, are coming from them. We're mere facilitators. It's really them coming up with improvements and stuff which since they come up with it, it's easier for them to actually execute it, right? Because they're very involved in it. And hence, okay, so just showing you some of the sample. This is some photos, right, of the solution. This is a sample of the dashboard on one area, on another area, and this is this is part of their hospital magazine and stockholder report. They made a route out of it. And here also shows you a nurse which tapped the card and the sensor. It gives you a sense of how the process looks. It's I would say it's the least intrusive of a way we found, which is very cost effective as well. And because of that, here are just some of the outcomes, and we're very happy, to share that the partners which we've had have achieved significant, outcomes, results, from ranging from 19 to 33% decrease in average length of stays, right? So, and these are just in the initial deployment months, and this is even November. I haven't. I just didn't have time to include the current ones, but it's definitely sustained. And okay, this shows you, well, taking one of those, this shows you how it gets sustained, and that's from now it's running with April and May data even. Overall, it shows you that there's an improvement in trend. There's a decrease in length of stays, and there's a reduction in variation. So there's more predictability in their performance, and a lot of these results, they able to achieve despite not without sacrificing factors like readmissions and mortality rates. So that means they're not doing things in haste. They really achieve outcome without sacrificing quality of service delivery. Right, so it also allows them to comply with their hospital accreditation. A lot of our current partners are with Joint Commission International. It allows them to comply with their standards as a bonus. And here it just shows you some of what they have to say about the solution. It's really, it has helped them a lot. It has provided them the eyes on the operation, which gave them comfort to see how they're doing and where they need to get better on. See, so that's a gist of what Storm does. Overall, we help our healthcare partners go from good to great, and that's how we position ourselves. Thank you very much. And I now open the floor to questions. I'm handing this back to you, Colin. Thank you very much.
Great. Thanks very much, Reggie. That's really great to see those results of something obviously very important, improving the quality of healthcare. So I'm just going to check briefly. Sumana from Nepal, I think she's been having some connection issues. So I'm just going to ask if we can hear her. And if not, we'll go to our discussion, and if she's able to rejoin, we'll bring her back in. Yeah, I'm not. I think she's not been able to reconnect right now. Actually, then I think with that, what I'd like to do, Will, is maybe just lead off with you as someone who's been studying across the region, you know, the healthcare challenges and writing about it and advising. You know, I think sort of the first big question is, what are the healthcare challenges that are faced by emerging countries that are, you know, not really perhaps on the radar so much with the developed markets? I think we've heard several examples here already today, right, with diagnostics and access, you know, in the provincial areas. But what's your view of kind of the landscape of how do we kind of classify the biggest healthcare challenges that you see in emerging markets? Oh, you're muted, I think, again, Will. Yeah, sorry.
There it is. Okay,
there you go. Yeah, here you know.
Yeah, it's an interesting question because you know, there are some commonalities between the challenges faced by healthcare systems in developed markets and emerging markets. And then, of course, there are differences. You know, in terms of some of the commonalities, we heard about some of the issues from some of the panelists already that are problems for everyone. So I believe Rubaiyat, if I'm saying that correctly, am I saying your name correctly? Rubaiyat?
Rubaiyat, yes.
Yes,
Rubaiyat, yeah.
Rubaiyat.
I believe you mentioned antibiotic resistance. So this is certainly something that, you know, antibiotics are definitely overprescribed, arguably more in emerging markets. I've seen, you know, I work in Vietnam right now, and I see like tremendous antibiotic prescription rates that just have no basis in common sense. And yet antibiotic resistance is something that ultimately could impact everyone. So is this an emerging market challenge, or is this a global challenge? It's an interesting question. You know, I guess it's an emerging market challenge in the sense that emerging markets are driving antibiotic overuse and creating, you know, potential for antibiotic resistance. There are also places where presumably there are fewer resources to address this problem, you know, when it does lead to outbreaks of drug-resistant bacteria or viruses or whatnot. So, you know, I mean, is it an emerging market problem or a developed market problem? It's sort of a little bit of both. But in terms of, you know, Colin, to your question, what are some of the specific emerging market healthcare problems? I think that we also heard about, you know, from your company, LifeTrack, as well as from Reggie's company, you know, there's problems with hospital overcrowding, and there's problems with workforce skills gaps. And so this is very much a problem that is pretty common across all emerging markets. And I would say that, you know, overall low levels of infrastructure, low levels of funding, and workforce gaps are probably the biggest emerging market healthcare challenges that I can think of right now. But let's see what else people think of.
Sure, yeah. No, I think that's really, really great. Actually, before we tackle the follow-up to that, I think Sumana was able to rejoin. In fact, it's probably going to be a good segue to our next question, which is going to be talking about infrastructure availability. But Sumana, we're really interested to hear what you're doing in Nepal and kind of the motivation of what you're involved with medication for Nepal and how you're using technology specifically to advance your mission. So I think you're unmuted. I'll turn it over to you.
Sure. Hello, everyone, and great to be on the panel. So I am a founder of Medication for Nepal. That is an initiative that started when there was an unofficial blockade in Nepal that really showed the vulnerability Nepal faces in terms of medicine security. Nepal imports a lot of its injectables and whatnot from India. So when there was this unofficial economic blockade, we literally didn't have anything. So this initiative, which now is an organization, is a non-governmental channel that I've set up that tries to support really the most vulnerable people, people who live below the poverty lines, who literally fall through the cracks almost every time. Those are the group of people that I'm trying to support with medicines, with getting specialized service, which they can only find in the capital city, Kathmandu. The way technology has been used in medication for Nepal is literally this concept of connecting, first of all, trying to gather the gaps that exist from the medicine perspective in this low resource setting. And I could not agree more with what Rubaiyat has said in terms of challenges remote area faces. And to add on to that, another problem of Nepal is geography and terrain, and the low level of the mobile penetration is really increased, but in terms of being able to use that mobile technology and being able to use that preliminary education, primary education people receive to solve the basic problems of healthcare is quite low. So from that perspective, it's really a matter of gathering information on what is really lacking in these areas where you have like 1 or 2 government health posts which rarely gets staffed or manned. And the people have to travel great distances to get basic medicines, or a simple problem, a simple cut gets infected and because they're unable to get medicines on time. So that is the problem that I'm trying to solve. It's a little bit of experimental mode where if it works, then it can be handed over to government. We're also trying to see if we can somehow manage the supply that exists. The drug companies pull out their medicines 2 months before the medicines actually expires, and you've got this low resource setting areas where they would really use it within those 2 months. There's also this question of, can we come up with a supply chain system and inventory management so that we use these medicines for these people who really can't afford the medicines. So that is what I do.
Excellent. Yeah, very important work, clearly, and so commend you for what you're doing and bringing technology to play to solve that problem. So with that, then we will go back to the panel. I think we've just heard from Will on what are some of the common and then also unique challenges that emerging markets are facing. I guess I just throw it open to anyone who would like to add anything to what Will said or react to the thoughts that he gave on that topic.
Sure, I would love to at least share.
Yeah, go ahead, Samana, and then Rubaiyat will go to you next.
Okay. So I'd love to answer that question from Nepal's perspective. I think we need to segment this question into 2 areas, whereas people who actually have funding, who have the monetary means to actually access the services, the doctors, the hospitals, and the people who really can't, who really poor people who rely on the government hospitals and government-free medicines. So in terms of challenges, I think the first and foremost that comes is the huge concentration of doctors and service providers, including nurses and hospitals, specialist hospitals, only in urban areas, and the remote areas being completely left out of the infrastructure altogether. I think that's the number 1 problem. And the number 2 problem that we have is this, at least in Nepal, slowly we're going to roll out national health insurance system, is this lack of risk pooling that exists. So that if one person gets hit with a big disease, like let's say cancer, then that person really goes completely in debt to support and to get well. And finally, the third problem is this rise of non-communicable diseases that we're also seeing in Nepal. There's a huge, I'm really concerned about this antibiotic resistant strain that's going to come up, and primarily in Nepal, the patient predominantly asks for shots rather than tablets because they have already traveled such a great distance and they are subsistence farmers, so they really can't afford to be on that course, be in the headquarters, take the medicine, see how it impacts them. They really want a quick fix solution. So for that, they see injection, a really strong medicine, as the ultimate solution. I think that's one of the main reasons why we're seeing a rise. And finally, one of the things that's really adding to the rise of non-communicable disease in Nepal is predominantly complete lack of focus in lifestyle. The processed food is taking a huge chunk of the market. Sedentary lifestyle. If you look at the geography of Nepal, people who are in rural areas and they're farmers and they're working, the cases of diabetes or high blood pressure is really low. what they primarily suffer from are trauma diseases when they take a fall from a hill, fall from a cliff. But if you go to a bit urban population like headquarters or cities, the incidence of non-communicable disease is very high. So it's very much a complete lack of focus in so what causes this, more a lack of focus on preventative measures. I think these are the four main challenges that I see, at least from Nepal's perspective.
Excellent. And then I think Rubaiyat, you were going to address that.
Yeah, I want to second everything that Sumana said. I think in Bangladesh we face pretty much the same set of challenges that Sumana mentioned about Nepal. But in addition, what I wanted to add was the lack and almost apathy of the government towards the healthcare sector, especially for the poor, because what we've seen in Bangladesh is the government, first of all, the allocation for healthcare in the budget is actually quite low compared to the global standards. And then much of that funding actually goes to just building facilities, but not ensuring that they're properly run, staffed, and managed. So like that ends up wasting a lot of resources, but not really adding to results for the people. And in addition to that, in Bangladesh, because we have a pretty thriving private pharmaceutical sector, this lack of regulation can mean a lot of, it opens up the room for a lot of malpractice and exploitation, because the pharmaceutical companies are trying to sell their drugs, and they're basically continuously trying to motivate these informal providers and the pharmacists to sell and oversell their antibiotics. And because of that, we're seeing a huge surge in antibiotic-resistant bacteria. Among the 10,000 patients that we've seen, like I would say as many as 15% of them are actually coming in with multi-drug resistant strains of bacteria. So those kinds of challenges are huge, and I feel that it's only going to get worse over time unless the governments really step in and works closely with the private sector to actually solve these problems together.
So I'm wondering, I think what I'm hearing from both of you is a lot of it is perhaps lack of the right data and the ability to measure the problem and to communicate, what those problems are, and especially when you start talking about how it gets funded, understanding this from an overall perspective. Maybe just briefly for each of you, how is that information collected? I imagine those of you who are kind of on the front lines, if you will, on the ground, see what's going on, but I'm wondering how well these problems are quantified and how that gets communicated, so that perhaps the policymakers can't ignore the problem.
Yeah, that was actually one of the founding kind of motivations behind GEON, because in addition to providing healthcare at the last mile, the data that we gather can itself be quite provocative and useful, especially things like, for example, what I just mentioned about the antibiotic-resistant bacteria strains. So those kinds of information simply don't exist in Bangladesh, maybe aside from some academic journals where some researchers are collecting some survey data to do a quick research. But I suspect governments don't read any of those journals. So they're not being properly informed about their policy choices that they're making. And so I think what M-Clinica does, Will was mentioning M-Clinica in the Philippines and in other countries, and they're doing some phenomenal work in gathering data at the grassroots and actually channeling it to governments and others at a large scale. And that kind of analytics can be super powerful. That's definitely one of the founding motivations behind us as well. And as we scale, we definitely want to leverage that the huge amount of electronic data that we gather from our patients. All of our 10,000 patients actually have EMR records. So with that kind of information, we can really influence policy, hopefully, in the long run.
Yes, I think very important. And Harris, if I can come to you, I'm kind of wondering, in Pakistan, you see similar issues when you get out into the rural areas, and then you, through the journey that you've been, and obviously the scale and scope that you've achieved, how do how are these problems addressed with through your through Shifa?
Yes, yes, I would surely like to share with all. After seconding whatever Rubaiyat, all that Rubaiyat actually said, I think the biggest challenge in emerging markets, healthcare markets, is that since the public sector healthcare facilities have not been up to the mark in terms of attending the masses, as well as in terms of providing quality healthcare care to the masses. That's the reason that private healthcare sector becomes overburdened, overcrowded by the patients, despite having the fact with us that we do face affordability issues here in emerging markets. So for the patients, the first challenge is affordability in the emerging markets. And the second challenge that becomes a huge challenge for the private sector hospitals is that we become overcrowded with the same patients who cannot afford that quality healthcare. That produces two gaps in the market. One is that patients get quality healthcare at high cost, number one, and number two, hospitals feel skill gap in the facility. And they are really challenged by the fact that when you're overcrowded in the facility, this becomes really difficult to maintain that quality of healthcare. So in emerging markets, I think the biggest challenges are that the things are not up to the mark from the public sector side. So private sector carries a huge responsibility. Then the private sector has this challenge that they have thin profit margins with them. With those thin profit margins, it becomes really difficult that you invest in innovations. So this is the second biggest challenge that emerging markets face. As William also highlighted, that when facilities are overcrowded, we face challenges of Rubaiyat also highlighted, that then corruption also comes in between. That negligences also come. So there's a lot of things. The other panelist was recommending that he was presenting the patient workflow. Now in Shifa, we face real challenges in controlling that patient flow, because the hospital is overcrowded by the patients who doesn't seem affording that quality healthcare. But whatever way they gather that those funds with them, they come to Shifa for that quality healthcare because they have to come. And this becomes then our responsibility. We take that responsibility on our shoulders. That is the reason that I earlier mentioned that we developed that Shifa Foundation, so that we help those patients, so that we we accumulate those funds for those patients, because ultimately we have to invest in innovations. We have to improve healthcare in emerging markets. So that's the biggest challenge. That's the answer to your question regarding infrastructure in emerging markets, because infrastructure is not supporting to that extent. The private healthcare sector is facing challenges in giving quality healthcare to the patients.
Yes, and so that's really great. And the foundation that you have then, is that just purely supported by Shifa, or do you work with other organizations who can help bring funds to those efforts? So how do you work on that?
Yes, it is supported by Shifa as well, and by other organizations as well, certain foreign organizations as well. But the more contribution is from Shifa's side.
Right, and then how do you then, or do you have any technology that helps you kind of support the people in the more rural areas, so that they don't have to travel and overcrowd the hospital? How do you deal with that?
Yes, we do have facilitation points throughout the country in the remote areas as well. And we do have technology integrated with consultant settings and facilitation centers. For example, we have facilitation center in northern areas, and the consultant sitting here can prescribe, can examine the patient in remote areas coming to facilitation centers. And then we have lab pickup points as well attached with those facilitation areas. And we get the lab samples from those pickup points. We get the diagnosis here in the lab, in the main lab, central lab here in Shifa. And that's the way we are helping patients in remote areas. But when things are complicated, patients are called upon here in the hospital.
Great. And then coming back to Carl, I'm wondering, Carl, if you can kind of talk a little bit more about, how some of these challenges, have led to actually innovation in terms of how do you distribute, information in a cost-effective way. And, obviously you're focusing on the diagnostic side, but talk a little bit about, some of the ideas that LifeTrack has applied to being able to, in effect, reduce the cost and speed the time that patients can get the correct diagnosis.
Sure. So I think just building on what a few of the other panelists have said, government policies can not only be like a cause of kind of inefficiencies in the system, but can actually actively disincentivize the adoption of new technology. So in our case, let me give you an example. So we're big fans of digitization of images, particularly X-rays, because that's the only way you can send them efficiently from outlying kind of areas or islands in cases of the Philippines and Indonesia to doctors in the cities. But you have cases in some countries like Vietnam, for example, which is a 90% public healthcare market where the government is the biggest payer for healthcare services, where the government requires a patient to bring film to the national healthcare insurance agency in order to get that reimbursement. So the cost of film is 4 times what it would cost to do it on a CD. And so these types of policies, where they were created back in, I don't know, maybe the 50s or 60s, when film was the only option, and then haven't been updated since. These are the kinds of things that we do wish that the public sector, especially the departments of health or the ministries of health in the region, take a more kind of proactive approach and say, look, this doesn't make sense anymore. It actually costs the entire healthcare system more money when we're still printing all this film. We should switch completely to digital. And what I'm hearing from this panel is encouraging, because people from the bottoms up are pressuring governments to be more responsive to these types of feedback that policies are actually promoting or distorting behaviors and disrupting the adoption of new technology because it's not flexible enough. In terms of actual new technology, I think a lot of the problems we face can be solved by distributing resources better and more efficiently. So that's the real kind of application of technology at this point, at least in emerging markets, is how do we enable people to access healthcare without having to travel 5 hours to the nearest hospital? How do we enable them to send their medical data more cheaply and get a doctor to do it for using and pay using prepaid cell phone credit? So telemedicine, teleradiology, distributed radiology, distributed cardiology, kind of these are the basic things that I think we're seeing in emerging markets. On LifeTrack's particular platform, we're also starting to work with some of the artificial intelligence companies that are based in advanced markets like Europe and the US, and we're hoping that eventually we can be the channel for them to apply some of their AI to diagnosing patients in emerging markets. And so obviously we want to be able to kind of leapfrog some of these resource bottlenecks by not just making the doctors faster, but in certain cases maybe potentially automating the diagnosis if there really is no access to doctors available for certain patients or certain areas.
Excellent. And Reggie, just want to kind of pick up on something that Carl just mentioned, which is sort of barriers to adoption of technology. I know this is something that you've been addressing. Maybe talk a little bit about your experience with, it's one thing to come up with the innovation and the idea and to get all the techie folks, the tech folks to put all the solutions together, and it's another thing to actually have it actually positively impact patients, right, through adoption. Maybe talk a little bit about how you see the challenges and how you've overcome them in terms of adoption of technology.
Sure. Yeah, definitely. Well, the way we did it is really we started with a problem. It's definitely a pain point which they want to solve, meaning whether they had our technology or not, it's something which it was a pressing issue which they had to solve, overcrowding, and that's been confirmed and repeated by a couple of us here. And so we started with that. But then, everybody also knew that, we didn't have data really as a solid base for improvement. And it's tough to get that. Typically, if we get first world technologies, it's kind of expensive. So the way we did it, so that's why we tried to be creative around it and get a really cost-effective technology. And we had to even be creative with our pricing. We had to, we can't come in and line up with their CAPEX, capital expenditure, because that's going to take a while. They have to put a budget around it. So we tried to make pricing really, very accessible. We made it transaction-based, so it becomes, very affordable. And then, as they get to do that, the only thing there is the moment they get to see what data can do with it, it opens their mind to a lot of things. So we remove the barrier. So typically the barrier would be the cost. So we brought it to a level that's transaction-based, so they're able to just easily kind of pass it on. And two, we work with them with data, because the next part is, okay, so we have this technology, we have this data, what do we do with it? So and hence we had to handhold them on that piece. And when they got, and then they realized that, with this type of data, we could actually do this. They feel empowered, and hence they get to do more. So it's, I would say we're very collaborative, and we had to help them every step of the way, really.
Great, that's great. Will, I want to address this to you. One of the common things I think I've heard from almost everyone here now is the policy side, right? That especially in a lot of these unserved rural areas, they're not necessarily getting the support that they need from the Ministry of Health level or the policy makers, and in terms of resources, and how do you size that up in terms of have we seen any models that as you've looked around the region that seem to be working in that area? One of the things that I suggested was perhaps better collection of data to be able to present the problem, so that the scale is understood. I think, Harris mentioned that it puts a lot of burden on the private hospitals when the public hospitals aren't able, to serve the needs adequately. What are your thoughts around the policy side of this?
So, it's funny that the last story I wrote was about 3 days ago, and I actually wrote about a policy shift in Vietnam where the government had decided they were going to connect hospitals in rural provinces. And this is a great policy, right? So they launched this new healthcare informatics network and system in some of these remote provinces. They used technology to collect more data to help reduce prescription errors, to do all these great things. And so what I wrote about was I attended the opening, the ribbon cutting ceremony where they went and, launched it, and all the politicians took their pictures, but the one thing that really stuck with me was that it was a great system, and yet, everybody from the government delegation and a lot of people from the international financing delegations that put the money into making this happen, they were all smoking the whole time. Everyone was smoking cigarettes, So we went to visit this one hospital with this amazing new IT system, and everyone was outside smoking cigarettes. We went to this clinic. Everyone was smoking cigarettes. We went to have a big dinner banquet. Everybody was smoking cigarettes, and they were drinking heavily, and they were having beer chugging contests, okay? And this is the Vietnamese government, the senior leaders of the Ministry of Health. So on the one hand, they had great policy. On the other hand, I didn't think that they really showed an understanding of what healthcare really is all about. So I guess ultimately I'm telling this story to make the point that, there's policy, but then there's also leadership. And I think that, in terms of policy, there's no one size fits all kind of thing. There's no sort of type of policy that's going to work across all emerging markets. But the one thing that I think really would work and would scale across all emerging markets if we had real leaders who encourage people to act and behave healthfully. And having worked in China, having done projects in India, Japan, Philippines, around the region, Indonesia, I always came across the same thing. Just like public health leaders are smoking cigarettes like on the job. And the final little story that I'll tell about this was before I joined M-Clinica, I was working with a consortium of German medical device manufacturers who wanted to enter the Vietnamese market. And so I had to make a call on the Ministry of Health up north. And so I went to meet the head of medical devices at the Vietnam Ministry of Health. And while I was waiting to meet him, they put me in a waiting room. And the waiting room was actually a smoking room. And so I was at the Vietnam Ministry of Health sitting in a smoke-filled room. So what we need is policy, but we need leadership too. We need people who have sensible mindsets about what health is all about and encouraging people to live healthier lives. And I think that is the kind of policy that every single emerging market needs.
Yeah. So, and clearly that's a major challenge to overcome. I'm not sure. Certainly, I wouldn't have the answer to that one. Maybe keying off that. So, along with obviously having the right policies, there also needs to be the necessary flow of funds, right? And I think one trend I know we've seen here in the Philippines, and I'm curious to hear how it is through the other countries represented here today, is there does seem to be larger scale investor interest in building out, certainly on the private sector side of healthcare. Just staying with you for a minute, Will, how do you see those trends? And does it seem to be spreading more broadly through the emerging markets, or is it just maybe in the countries that are experiencing the most rapid GDP growth because they have emerging middle classes who can afford private healthcare? Or how do we sort of tackle the funding challenge? And then after you, I'd like also to hear from Sumana and Rubaya how they're funding that they're doing.
Well, okay, so Colin, unfortunately, about a third of whatever you just said got cut off due to my connection.
Okay.
But the question is about the financing gaps and how can policy address the financing gaps? Is that correct?
Yes, that's the essence of it. Yes.
Okay, well, this comes actually back to something that our friend from Nepal, who I'm not sure if she's here again, it looks like we might have lost her.
She dropped off, yeah.
Yeah, but which she mentioned in her talk, which is the importance of insurance. And, I mean, right now, there is a move in some of these markets towards public health insurance, towards greater public healthcare coverage, which in theory is nice. I'm not sure if a lot of these governments have the institutional capacity to effectively manage a public healthcare system. So I personally believe that private insurance is going to be a major, a major driver towards expanding access to healthcare financing. So I've been talking to and writing about a lot of the private insurance companies and the work they've done to develop insurance products that are suitable for these markets. I think that they're going to make a lot of difference in that. In terms of what the public sector can do, that's really complicated. I don't even know. I feel like, ultimately, public, single payer, like universal healthcare coverage systems in well-run markets is the gold standard. But I don't think that most of the countries that we are all collectively representing and working in have the capacity to effectively run those kinds of programs yet. Will they get there? I think so. Do they need to try and start doing it in order to get there? Yes. But I think that today it's really got to be a public-private mix. And I think a big part of the policy side of it is that I think government should do more to open up markets for private insurance. I think that that's going to be a major potential driver for expanding coverage and access to healthcare financing. That's just my opinion. We'll see what you guys think.
Well,
Colin,
yeah, so
Colin,
go
just
ahead.
one question on my end. I mean, to that perspective, there's really a lot that partnership with government can do. My question, my thought right now is to some extent, let's say this global chamber will it be looking at, say, partnering with government or to some extent maybe in the future, I don't know.
So you're suggesting we could be part of the solution, hey Reggie? and actually, certainly we do. We're fairly new in Asia. We have a presence right now in the Philippines and in Japan, and actually in most of the regions that are represented by the panelists here today. But fairly new, and we're building those relationships up. And I think that's really actually, hopefully, by bringing awareness throughout the community of what some of these common problems are, and looking at different models that are being tried in different areas, I think is something that also has some value. But we're willing to sign up for the challenge, Reggie, if we can form the right relationships at the government levels. Need your help on that one.
Well, I'm sorry. Can I just take this moment to ask again, because I wasn't here for the first few minutes. What is Global Chamber?
Sure. Yeah. So Global Chamber was started just only about 3 years ago in the U.S. Actually, the first chapter was in Phoenix, Arizona. But it's grown very rapidly. We're now in 150 metropolitan areas around the world, and like I mentioned, just a handful so far in Asia. But the idea is that the basic value is to bring together trusted connections. So what we're trying to do is build trusted connections and networks through both the business and the government sectors, also the academic sectors in each of the cities where we operate, and then look for ways that people can grow internationally and solve problems internationally through making connections that don't exist today, and to collaborate with the business associations and the country chambers, right? So certainly in every city, for example, here in Manila, we have many country chambers that are quite large and effective. AmCham for the Americans, and European Chamber for the Europeans, and the Spanish Chamber, etc. But oftentimes they're operating a little bit siloed and not necessarily tackling common problems that exist, or tackling common opportunities that exist. And so that's really the main focus of Global Chamber, is really to make those trusted connections in a much larger network. And as the network grows bigger, of course, there's more value in that. And so, for example, I think we're projecting by the end of this year to be in 200 metros, and actually have a growth plan to be in over 500 metros by 2020. And I think as we kind of achieve that scale, then we can really sort of be the matchmaker, if you will, to bring folks together to both open up opportunities for international trade and expansion, but also tackle some of the common problems.
Colin, I would like to add to what William was saying. We have talked a bit negative side of the story for a while. Now, the positive side of the story is that the private sector has produced that awareness in the masses that pushes the public sector, that is actually pushing public sector towards doing something. So, for example, for instance, in Pakistan, the government has initiated the public-private sector partnerships. For instance, particularly in our hospital, the government has picked the best consultant we had for kidney and liver, and the government has given all the fund to the consultant and said that you will run the project. This will be an autonomous body, and that project actually encompasses 36 hospitals throughout the country, 36 centers that will address just liver and kidney transplants. So the positive side of the efforts done by the private sector is that those efforts are pushing public sector towards doing something for the masses.
Yeah, I think that's great. I think, as you say, as you basically build up really sort of the competency levels of the private sector, right? Then that creates a vehicle that hopefully public sector money, can flow into, because it's an efficient way of achieving, measurable results. So, I think you're right that we should look at the success stories as well and learn those lessons and figure out how do we replicate those and see more of them. Correct. Yeah. So actually, I think time-wise, we're closing in on our available time. So what I'd like to do is maybe just have each of you have an opportunity just to sort of sum up, but to address any of the points that have been made so far, and just give final thoughts. And if I can start with you, let's maybe go reverse. Start with you, Reggie.
We lost Reggie.
Oh, okay.
All
right. So. Yeah, Houston, we have a problem. Okay, then actually, Will, so since we've got you up on the screen, let me ask you just to give some any final thoughts, respond to what we've been discussing today.
I mean, it's a nice selection of people. I'm happy to meet all of you and hope to be in touch with you going forward. I actually had a question for Rubaiyat, if I could, in these final minutes.
Absolutely. Absolutely.
Because I haven't heard of Jian before, but I came across a company not too long ago where I think you were involved, and which sounds very similar to what Jian's doing, which is Manpower. So I met Int'l a couple times on the USA development circuit, and I think you guys won a div grant. So I'm just curious how you guys, how your work at Jian fits together with that, because I saw on your LinkedIn you're also part of Manpower as well.
Yeah. So I'm one of the co-founders of Manpower as well with Int'l. So Manpower is quite sector agnostic at this point. Manpower does a lot of work in agriculture. Essentially, the same technology that drives Jian now was originally kind of conceptualized and initially used within Manpower to address a range of development problems in different domains, including agriculture, education, water and sanitation, and others. So Jian is very much focused on the health piece and looking at informal providers as a distribution channel for telemedicine and other healthcare innovations, which is a slightly kind of a more focused approach on a particular piece of the problem that Manpower has been trying to solve. So Manpower's clients are typically governments and nonprofits, whereas we are taking an entirely private sector, direct-to-consumer kind of approach to solving this problem.
I'd love to hear more about it sometime. I'll visit you in Dhaka one of these days.
Oh, yeah, absolutely.
Yeah.
Look forward to
Are you
that.
based in Dhaka?
Yeah.
I'm in Dhaka, yes.
Cool.
Yeah.
All right.
So there you go. First of all, I think we see it indeed continues to be a small world. Folks involved in these projects are maybe in a way, and also maybe give you an illustrative answer to your question. That's kind of what Global Chamber does, is we try to bring people together through virtual events, online events, other types of mechanisms that we use to get people connected to each other, talking to each other, exploring synergies, and tearing down, the borders that exist there, right? And making ideas flow more freely around the world. So that's really what we're trying to do. And so actually, Rubaiyat, just staying with you for additional minutes, one of the questions I want to ask you is, how do you fund, how do you fund the work that you're doing with Gian?
Yeah, I was going to answer that when you asked the question before. So
Yes.
currently we have an angel investor putting in some seed funding, and we also got some grants from USAID and another foundation in the US. Innovations is that it often takes a long time. So there's often this cliff initially after the seed rounds. Getting the next round of funding for growth and scaling often becomes quite difficult. And so we are currently at that phase where we're just running out of seed funding and we're looking for kind of a Series A, but it's not clear who is actually funding those kinds of innovations at scale and taking them to scale successfully. So I think there are some funding gaps there that the global community needs to address. But also, just to wrap up, I'm taking this opportunity to share my closing comments, which is that even within this group, I think there's a lot of opportunities for collaboration, and we're all tackling different pieces of the puzzle, and unless we work together collaboratively, I don't think we can solve this huge and global problem. So I look forward to connecting and staying connected with all of you and finding opportunities for collaboration. So thanks for inviting me to this. Thank you.
Excellent, and likewise, we're looking forward to continuing to learn more about you and connect. I think the very beginning of what your answer there got a little bit garbled from the internet connection, but I think what I heard was you had up to this point been sort of angel funded and perhaps some funding also through USAID. Did I hear that correctly? But now looking for that next level. So. Hopefully maybe there through this event even there'll be some new connections made that will help hop on that front. So delighted to have you. Let's see, let's go to Carl and closing thoughts, Carl.
Yeah, just echoing what Rubaiyat and Will already said, which is that it's really energizing to see how we're all trying to deal with these problems. We all see the same problems, and we're approaching them from different angles. And I already know that I'll be reaching out to a couple of people on this panel after to catch up and see if there's any opportunity to work together. But I think for me, the takeaway from this panel, besides that, was just the importance of us as disruptive private sector players to not ignore the fact that the public sector will still play and will continue to play a huge role in healthcare, and that to the extent that we all deal with stakeholders from the public sector all the time, it's our responsibility to keep that dialogue and to push them to, I guess, improve the way that they deliver their own services and try to find ways to collaborate with them to change the system from the inside.
Yes. I think I've also got that takeaway. I think it's very important, Carl, that individually maybe it's difficult for each of us to make much of an impact. Maybe collectively, as we tackle these topics and collaborate, there's ways to have a bigger voice. And I don't want to overlook anyone. I think Samana, unfortunately, was not able to reconnect. So let me go to Harris for closing thoughts.
Yes, thank you, Colin. It was really a pleasure having such diverse team of panelists here. It was really a good learning experience. I would like to again end up my closing remarks with the positive note. Healthcare is not a business. We must reiterate the fact in the light of discussion today. Healthcare is not a business. It's a contribution. It's a contribution that we all have to make through collaborations, and I see a lot of opportunities even in this panel that we can collaborate and we can contribute towards improving healthcare in emerging markets. That's a contribution. That's not a business. The positive side, again, I would like to highlight is that governments have been pushed to do something because of private sector contributions, and we do see that nature fills the gaps over the passage of time. And if I don't fill, you will fill sometime in future. So the positive side of the talk is that we are moving towards a right direction. Through such forums, we can improve collaborations amongst us. We can contribute to the development of the betterment of healthcare in our countries.
Excellent. Well, again, thank you for your time. It was really interesting to hear about your hospital and then the work that you're doing, and there are also some of the positive things. I think it's very important. And Will, I'm not sure if I allowed you the full closing thoughts or not, or was there anything else that you wanted to add?
I'm sorry, you're talking to me?
Yes.
You say my, okay.
Yes. I just want to make sure that we have given you a chance to make any of your final comments.
Oh, my only final comment is right after this, I'm going to go to the gym. I think that another important thing is that as healthcare professionals, we need to all strive to be healthy. This is the kind of leadership that I'm talking about, which I saw as being lacking in the public sector in Vietnam. I think that, we need to not smoke, drink modestly, work out constantly, be healthy people. Let's do it.
Yeah. Well, excellent. I think that's fantastic advice for all of us. So thank you very much. Just to wrap up, it's been a pleasure having all of you. Thank you very much for all of your time. As I said earlier, we're trying to use opportunities like this to tackle particular topics and shine a light on thoughts and ideas and innovations that are happening in different areas. So I think it's been really great, the information that we've heard today. We have recorded this session and will be making it available. I know we had a lot of interest actually from our members in the US to be educated on these topics as well. Who knows, maybe there's some funders there who'll be listening to this later. So because of the time zone issues, those folks have indicated that they'll be watching on demand rather than live. So any feedback that we get from those follow-ups we'll be sure to pass on to each of you. So again, thank you everyone for your time, and wishing you good health